This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, she's a 65-year-old lady who's having this intermittent cataract. The lens is very much swollen and the patient is also anxious. She's keeping on moving her eyeballs. I have decided to go in with the pre-planned topical anesthesia with the intracameral lignocaine. The side ports are made. The intracameral anesthetic is used, followed by staining of the entercapsule. I'm using dispersive OVD to deepen the chamber and the main incision is performed. Now this was a case with intermittent cataract and initial plan was to do smaller Rhexis and then assess the situation. But as I begin the surgery, a sense of confidence, or rather I should say overconfidence, built into me, and I thought I could pull this off in a single setting itself. So I didn't want to do a two-stage Rhexis. The Rhexis looks to be very well in control until I realized that at this point I'm losing control and it just goes off. I tried the Rhexis rescue maneuver as well, but it's too late. The chamber is shallow and it's gone too far periphery. The timing is extremely critical. Well, overconfidence and a little bit of complacence took me to this situation. If I look back, I think I would have done certain things differently. When I knew that it's heading towards the equator, I should have stopped, refilled the chamber with OVD, and the rescue maneuver should have been attempted through a different port rather than the same incision itself. That would have probably given me higher chance of success in retrieving back the Rhexis. Nevertheless, it has gone out now. Now how am I going to deal with this situation now? So I'm using a micro scissors to make a small snip at this flap and then try to complete the Rhexis. So I have a weak area in this part, and this part is vulnerable to extend beyond the equator onto the posterior capsule during nucleus manipulations. So this has a potential to run off beyond the equator and go into the posterior capsule, causing a posterior capsule tear and a potential nucleus drop as well. So I need to be extremely careful in my nucleus division techniques and always keep a watch on this area. Of course, the strategy is not to do any hydrodissection or nucleus rotation. First, I go in with my phacoemulsification probe and aspirate the superficial epinucleus in the cortex. So I'm going to create a small trench before doing my first chop. This is just to ensure that I get a very firm grip on this nucleus. So I create a small central trench measuring about 30 to 40% depth, which is sufficient for me to bury the tip deep before I do my first chop. These are the settings which I'm using for chop, and then the first chop is initiated. I'm using a vertical chop technique here. The strategy is to just start chopping, and then once the first piece is chopped out, remove that small pie fragment out. This will create more space in the bag, and this will help us to minimize the stress when you're trying to rotate the nucleus. So that's the plan here. And we have a first fragment which is free now, and this pie-shaped fragment is pulled out of the bag and emulsified. This will create some space, and a nucleus manipulation now is not going to exert any stress on this weak area now. Time to perform the second chop. Again, the tip is buried, the vertical chopper goes down and then laterally, and we have a free piece again which is pulled out of the bag and then emulsified. Now there's significant amount of free space within the bag now. I can rotate the nucleus now without a major concern of stretching the bag during these maneuvers. Thankfully, the nucleus is also very brittle, so when I'm trying to chop, it's not really bothering me much. I can divide the nucleus without inducing any stress on the bag of the zonules. The second heminucleus is then divided into 3 smaller fragments, and then each of them are emulsified. So the basic principles I'm going to follow whenever I have a Rhexis which is run away. Usually my strategy in most cases is going to divide the nucleus into smaller fragments, keep them all in the bag until the last fragment is divided, then aspirate them individually. On the contrary, when we have a situation where the Rhexis has gone off radially and we have a weak area, this is a situation where I would like to empty the bag, at least the first 2 fragments immediately after chopping. The reason is we have got extra space within the bag, and further rotation and manipulation of the nucleus is not going to induce any stress on this potentially weak area. So that's the idea, and that's the strategic shift which I do whenever I have a Rhexis runoff. That is, create space in the bag by emulsifying the first two fragments. Now all the fragments are taken care of. Now it's important to focus on the next big principle, that is never to allow the chamber to shallow. So before getting my phaco probe out of the antechamber, I'll be injecting OVD through the side ports just to ensure that the chamber does not shallow. When the chamber suddenly shallows, there's always a risk of this peripheral extended tear extending beyond the equator onto the posterior capsule. So extremely important to maintain the chamber equilibrium. That's what I'm doing now. The cortex is being aspirated all around, and extra care is taken while trying to remove the cortex under the area of the Rhexis extension. Again, I'm going to inject OVD inside the eye before pulling out the irrigation through my left hand. The chamber is deepened with OVD followed by implantation of the intraocular lens into the bag. Care is taken to ensure that the haptic is away from the area of the Rhexis which has run off. The residual cortex is removed, followed by aspiration of all the OVD both in front and behind the intraocular lens. Time to close, but there's a lot of positive pressure which is pushing out the lens, and the lens is popping out of the bag. So I'm going to spend some time in trying to hydrate the wounds properly and ensure that the lens is very well centered and put inside the bag. Finally, it looks well settled, the lens is well centered, and the wounds are looking very secure. That's it, the case is done. To summarize, 2 or 3 important principles to follow whenever we have situation of an extended Rhexis. Obviously, the first point was this could have been easily avoided had I been a little bit more slow and careful. Number 2, whenever we have a situation where the Rhexis is extended, my strategy is always to ensure that least amount of stress is induced on the stone margin, and one way to ensure this is that once I get the first chop, I take out the first pie of nucleus out of the bag, and this will create more space, and further rotation or manipulation is going to induce lesser stress on this weak area. So that is what I do. So initial rotation of the nucleus, hydrodissection, everything is avoided, and nucleus maneuvering or rotation is done only after a couple of pieces are emptied out, which creates a little bit more space, and even a bulky nucleus is unlikely to induce much stress on these torn edges. And lastly, I would never allow the chamber to shallow. At every step, I would ensure that the OVD goes in before the irrigating handpiece comes out, whether it be a phaco handpiece or even your bimanual I&A. So this ensures that the equilibrium of the chamber is maintained always, and by following these maneuvers, the risk of the Rhexis runoff extending posteriorly onto the posterior capsule is minimized significantly. That was it. Thank you for watching and hope you found this helpful.